Now, the first thing you may be wondering is, why do I need a business case for safe patient handling? And a possible answer is, you may not. It could be that your organization has already decided to go ahead with it, or there's a regulatory mandate, or you've gotten data from one of the vendors which tells you a little bit about what you can expect from program benefits, and that's enough to move forward on. But you might need more than that. You might have a struggle in your organization to compete for funding with other competing funding priorities. You might not be sure about what the scope of your effort should be and how many of the therapeutic areas you should put equipment into, whether you should do the portable equipment or invest more in the overhead lifts. Or you may be wondering, how do we identify what the value drivers are to really get the most value out of our program? And lastly, when it's all done, how do we measure to verify and validate that we're actually getting the value out of our program and we're getting the return on investment that we hope we're getting? To answer those questions, you need to go a little bit further, and you may need to go into this area that's called decision analysis, which is all about making high-quality decisions under uncertainty in cases like this.
So in 2009, we needed to do a cost justification for the overhead systems in our new hospital. The return on investment for the Safe Patient Handling program for the overheads was not there when you just utilized the workers' compensation and lost and restricted days. One of the things that we had heard about was this value-driven approach at the School of Engineering at Stanford. The program taught us new methodologies to do cost justification on things that were hard to quantify, which we knew that there were significant benefits associated with the program that we had not yet quantified, nor did we have historical data. We took the information, we took the classes, we developed a return on investment, and successfully moved our program forward for the overhead systems in our new hospital.
Decision analysis works very simply by breaking a decision down into pieces. We have the alternatives, which are the different things that we could do. In the case of safe patient handling, do you go with portable or overhead equipment? Do you go into the care areas where 90% or 100% of your patients require total or substantial assist, like the ICU? Or do you go downstream into some of the areas where maybe only 60 or 70% of your patients need that level of assist? Those are the kind of things that we think about for the alternatives. We need to think about the uncertainties and the risks, which are all the things that our program hopes to change. And then we need to think about preferences, which is how you value investments in your organization and what you do for a rate of return. We put all these pieces together in a quantitative model so that we can conduct these thought experiments and explore, what if we do this? What could the results be? How could we drive the value in our organization? Another reason that you need to go down this road is that even if you've gotten predictions or data from vendors about what you could expect from a typical safe patient handling program, the real data that we're interested in is the future data that will result when your program is actually implemented. That data doesn't yet exist. Now, in a data-driven world, it's a real challenge for people to think of moving beyond the data to thinking about uncertainty that you can't represent with data, which is why we need a decision analysis approach to thinking about uncertainty. Now, making this leap from thinking only in terms of data to thinking in terms of subjective judgments about future uncertainties, like the results from your program, is a huge challenge for risk managers and program managers in all organizations. Because you've seen it, I've seen it at so many meetings. Where's the data? Now, because we're interested really in the future data that doesn't exist yet, we need to supplement the data that we have with these subjective or Bayesian probability assessments. Now, this next slide shows what I sometimes call the spaghetti and meatballs diagram, or what all the risks and uncertainties were that we came up with for the Safe Patient Handling program at Stanford. We thought about the things that people typically think about, like workers' compensation costs that result from injuries to caregivers, the lost and restricted days for staff who aren't able to be at full duty because of an injury. But then we thought about other things that people don't typically include in their program, like the potential effect on turnover. So you may have seen the statistic that the physical demands of the nursing profession are the single biggest reason that people give for leaving the profession. And you may have also seen the data that it costs somewhere between $60,000 and $80,000 to recruit and train a new nurse. Well, guess what? If you put those together with a good quality subjective Bayesian estimate about how much you could reduce turnover, you can put a simple model together about what the value is from your safe patient handling program from reducing turnover. If this many fewer people leave, then that saves you the $60,000 to $80,000 recruiting and training costs for each person who doesn't actually leave. And that's the process we went through at Stanford, which is we went through all the potential sources of value, and we thought about, well, what's the range of uncertainty in the effect that we could have on this from our safe patient handling program? In the case of turnover specifically, we thought, well, Stanford's a very desirable place to live. And my colleague Ed Hall has a statistic he's very fond of about the number of people who applied for jobs at Stanford Medical Center versus how many are actually hired, to proudly conclude that it's actually harder to get a job at Stanford Medical Center than it is to get admitted to the university. So we said, well, maybe on the low side, we have no impact on turnover at all. Maybe on the high side, we could reduce it by as much as 20%. Not a huge impact, but we've taken a big conceptual uncertainty, like the impact on turnover. We've quantified it in terms of a Bayesian uncertainty range between 0 and 20%, and from that we can calculate the uncertainty and what the impact on the total program is. Now, when we've gone through and done this for all the things that we've been interested in, and it varies by institution, I'm finishing another large project right now where they were actually very interested in the impact on hospital-acquired pressure ulcers and patient falls, which was not a big factor at Stanford. So this is another reason that you may need an individual look for your institution, because the things at your institution may be different than what was important at Stanford. But going through and looking at, for each of these ranges of uncertainty, what if it was at the low end of the range? What if it was at the high end of the range? How much does that change the program value? Well, that gives us a range that we can plot on a bar graph. And if we plot all those from the biggest difference to the smallest difference, you get a diagram that looks like this one. The characteristic shape is why it was called a tornado chart. I also like to call it a tornado chart because it shows what could blow you away. So in this case, the tornado chart for the program at Stanford showed that turnover was actually the biggest potential value driver for the program, and you could actually almost double the value of the program by trying to drive the result that you get toward the higher end of the turnover reduction. And that changed the way that they thought about implementing the program. So they thought, well, gee, we need to include in our employee communications, communication to our staff to let them know that we're putting these measures in place so that they can continue to do their job. And maybe also we need to think about in our employee satisfaction surveys, asking questions to see if this is impacting our employee satisfaction, which I'm sure is a big thing at your institution as it is at Stanford. So by thinking about things in terms of these ranges of uncertainty, quantifying the impact, and then seeing which ones make the biggest difference, not only do you identify what the key value drivers are for your program, but you identify ways that you can get more value out of your program. And that's what we get out of the tornado chart. Now, reality, of course, is that one thing is not varying at a time. Everything is varying all at the same time. Now, when you have all these different things varying all at the same time, and because we've done probability assessments, we have probabilities of those, and if we look at all the different combinations, we start to generate an awful lot of scenarios. Thousands of scenarios typically, each one of them with a probability associated with that. And if you think back to the dark days of statistics, what does that sound like? That's a probability distribution. Now, most people remember probability distributions as your bell curve, which is hard to read from when you're trying to get implications of that. So I like to show it in a form where you add up the area under the probability density curve as you go from left to right, which, again, digging back into the basement, that was integration. Remember that? So if you integrate it, you get this kind of a curve, which is a cumulative probability distribution, and you can read some things off of it very simply. So we can see that in the worst case scenario, where we had the minimum program benefits and the maximum program costs, we still had about a $2 million program value. In the optimistic scenario, where you're getting more out of these ranges of uncertainty on the benefits, you have about a $10 million program value, and the mean of this whole thing is about $5 million. So in the prior work that they had done at Stanford, looking only at the stuff that people typically have data for, which is the workers' compensation costs and the lost and restricted days, they thought they had about a $2 million program. When we looked at all of the very real but hard to quantify sources of benefit, they had about a $5 million program.
The outcome of the VDERM process allowed us to get cost justification for over $5 million in new equipment for the overheads, which will allow us 100% coverage in the new hospital.
Now, for another institution I worked with, the answer was, you may or may not be able to pay for it from the workers' comp and the lost and restricted days because they already had a program in place, and even getting better at that wasn't going to pay off very much. But the payoff in the patient falls and the hospital-acquired pressure ulcers was huge. So the elevator speech to the executives is, yes, we think we can track the data to pay for this based just on the workers' comp and on the lost and restricted days. But if you look at all these other things, we're talking about taking 4% out of the cost of care across the whole system. So those are the kind of simple answers that we get to that are really what the executives want to know, the short and pithy description of what you should do and why. But until we've gone through the process, we don't know what the 2 or 3 sentence answer is that will be right for your institution as opposed to what it was for other institutions. Now, the last part of getting the value out of your program is following up as you're implementing to look and see, are you actually realizing the benefits that you predict out of this? And that's a further use of the tornado chart, because the tornado chart shows you for each of the categories of benefits where you should be tracking if your program is successful. So if a particular piece of data that you're tracking comes in outside of the range that you had in your tornado chart, you need to ask the question, what's going wrong and why that we're not getting the value out of the program? What they found at Stanford was that their baseline in workers' compensation costs was growing much more rapidly than they had predicted. So they had to take a look at that and find out why, and the answer was that a return to work program, which got injured people back to work in restricted duty faster, had actually been discontinued. So they needed to reinstate that program to fix something that was preventing them from getting the most value out of their program. So it not only provided for Stanford a complete quantification of what the value of the program was, an investment-grade business case that could substantiate investment in it, it also provided a guide for tracking and validating the program value going forward. Now, you're probably sitting there thinking, oh, this is a lot to take in the course of a webinar. And there's no expectation that people need to become an expert in decision analysis to be able to make use of this methodology. The analogy I like to use is accounting. So there's a lot of people who know how to read financial statements, but far fewer who know how to prepare them, and even fewer who know how to audit them to make sure that they're valid. The main thing we wanted to communicate today is that it's entirely possible to quantify what the total sources of value are in your safe patient handling program, to be able to display them in such a way that you can identify what the best program is for your organization, and to justify the investment required to make it happen, and then afterwards to be able to track and validate that you're actually getting the value out of your program that you're hoping for.